My guest in the studio, Dr. Lee Gross, physician from Florida. Good morning, sir. How are you? It's good to have you, and welcome to Mississippi.
Thank you. Thanks so much for having me.
What time is the event today?
I believe the event today is at noon.
At noon today? With vittles, I'm sure, so we'll, that'll be taken care of. Well, welcome to the state. It's an interesting topic, and for folks who don't know, it says Dr. Lee Gross is a brilliant physician from Florida. So I want to make sure we put that in here, coming to Mississippi to explain how he provides affordable health care to ordinary families instead of asking for insurance or for Medicaid. How is that possible? But share some of the thoughts and what people will hear today during the presentation.
Yeah, so the name of my practice in Florida, I'm in Southwest Florida, I'm a family physician. The name is Epiphany Health, and Epiphany is a very strange name for a healthcare company, but in fact, we had an epiphany. We were a fully insured practice, seeing thousands of patients, rifling them through every 5 minutes, trying to generate as much billable revenue as possible, because that's how you have to keep a practice afloat. And our insurance premiums as an employer kept skyrocketing. All of our patients' insurance premiums kept skyrocketing. And so we had a moment where a small business owner came up to us and said, "You know what, Doc? My insurance premiums for my employees, I can't afford to keep doing this, but all my employees see you as their doctor. And I see what I pay them, and I see what they pay you, and why don't I just hire you directly to take care of my employees?" And so that was our epiphany moment, was why are we insuring primary care? Why are we inserting so many people and so many barriers and obstacles between the doctor and the patient for the most basic aspect of care, filing an insurance claim and then complaining that you have poor access, it's impersonal, it's expensive, and it's cumbersome? So what we did back about 12 years ago is we created a subscription-based primary care service where we charged $80 a month for adults and as low as $15 a month for a child. And after that, we charged nothing for the services we provide in our office. So unlimited office visits, unlimited technology visits, unlimited procedures. And interestingly, once we launched this, instead of the small businesses, we saw uninsured patients come to our practice from all over the state of Florida. It created a unique challenge in that we had all of a sudden an explosion of uninsured patients into the practice that needed now affordable access to labs, affordable access to imaging services and physical therapy services. So it forced us to create a cash-based network of service offerings within our community, and we developed an entire marketplace of affordable cash services. Well, it turns out once we did this, it was actually cheaper to pay cash for these services than to use your insurance and the copays.
But you can't do without the insurance, can you? I mean, you're talking about standalone. It's sustainable without any insurance at all?
So the vast majority...
What happens when you have catastrophic illness, a cancer or something of that sort? Or what happens if whatever you look at, you can't diagnose in a simplistic way, and you say, well, we're going to have a series of tests and x-rays, et cetera. What happens then?
Yeah, so insurance is very good at major medical stuff, catastrophic things, the unpredictable. The routine services, which is probably about 85%, or the shoppable care, that actually is in most cases less expensive to pay cash for than use insurance. So I'm not against insurance. I think insurance is a very useful tool, but we're using it wrong. We're using it for routine care as opposed to the unexpected major services. So use your insurance for your heart attack, use your insurance for your cancer, but don't use your insurance for your diabetes management, for your asthma, and to control your high blood pressure. And so it actually gets much more affordable if we strip out the routine services and use insurance clearly as a hedge against a catastrophic loss.
What do you think would happen? Have you seen this in Florida or any other place as far as your practice is concerned? Once you expand things like Medicare or rather Medicaid, it is beneficial as far as the health results at the end of the give it a year, 2 years, 5 years. I always have a problem with that in the state of Mississippi, and we say whether regardless of what the program is, that it is performance-based to the point where we come back and look at it and say, are people healthier? Are they better off? We had a report, and one of the things that we just passed in the Senate was postpartum for those in that income level who can't afford it and they are pregnant, and we understand that, and I think it's a great idea. But then you go back and you look at the deaths that transpired, and I think it's one of the questions that have got to be asked or answered, is a lot of these people, if this research is right, were already on Medicaid that had that passed away. And then we go back and look at the long long service that we've given to the people in the state of Mississippi on Medicaid. I think it's over 750,000 or more. And the health situations in our state's no better. How do you address that? In other words, if the program is working, then we should have less people on it year after year, decade after decade.
Yeah, so Florida is also a state that did not expand Medicaid. And I can tell you that Medicaid patients also travel great lengths because they can afford, the type of services that we're offering. Mm-hmm. If they can afford a cell phone, which most of them can, then they can afford the routine care that we provide. But if you expanded Medicaid without expanding the number of service providers that accept Medicaid or will take a Medicaid new patient, then you're actually blocking access to the people that truly need it. So the truly indigent people that need that social safety net, if we throw more people into that don't necessarily need that, but need more affordable access to routine care, you're actually blocking services. So to expand Medicaid without addressing the underlying faults in the Medicaid program that keep providers and service providers from accepting that care. The reimbursements are horrible. The amount that they pay is barely enough to keep the lights on in most situations, and the bureaucracy of trying to interact with the Medicaid system is extraordinarily cumbersome. So that not only is it poor pay, but you have to put in immense resources, human labor resources, just to capture your money.
This is Dr. Gross. He's in town, Dr. Lee Gross in town from Florida. He'll be speaking at the Mississippi Center for Public Policy and also at the AFP at an event today. He said it was at noon today.
Yes.
I'm wondering, is this also called the concierge service type along that definition?
It's called direct primary care. It sort of stems from concierge, kind of like when...
How are they different?
Usually with concierge care, number one, the services tend to be a lot more expensive. Instead of tens of dollars a month, they'll charge $100 a month, and usually they will also then bill insurance for everything that they do on top of that. Whereas the direct primary care, the membership levels are usually less than $100 a month for an adult, and as low as $15 a month for a child, and everything is included in that membership for the primary care services. So the interesting thing is that as a primary care doctor, if I'm not burdened down by all of the nonsense I have to do to interact with an insurance company, I have a lot more time with the patient to actually provide the services they need. So instead of 5-minute visits, I have 30-minute visits, and so I can now manage your diabetes.
Do you cut most of your paperwork out on that one? You don't have to follow the paperwork rules on any of that?
There is no paperwork, which I think, and again, you mentioned the rules. That was an extraordinarily important thing for us, especially around the pandemic, where most of these practices had to shut down because they didn't have telemedicine built into their practice model. They had to wait for Medicare to improve telemedicine services, and so they actually had to not provide services to their patients. Whereas on day number one, we've completely flipped how we provided services. We went from an in-person practice to an online practice, didn't need to wait for a convening of an insurance committee or an act of the legislature. We take back to Hurricane Ian just several months ago. Our practice took a direct hit. Almost every practice within our region was shut down, had no electricity, was flooded out. On day number 2 after the hurricane, we opened up in the parking lot. We were, because we provide unlimited care, we didn't need to worry how and where those services were provided. So we provided them on the front porch. We did stitches on the back porch. And so the flexibility to provide the needs of the care for the community, but we can only have built this network of services that we provide because we have competition within the marketplace and the healthcare system in my region. So I'll give you an example. As a chest x-ray in a patient that pays cash in my area is about $25. An MRI is $250. That's without insurance. That's cash. Now, if you wanted to get an MRI with insurance, you'd probably have to do 6 weeks of physical therapy to get it authorized, $50 copay per session. When it's finally approved, you're probably going to have a $500 copay for that MRI. And so it takes you 2 months to get the MRI, but they approve it and you're paying twice as much for the MRI. So what are we insuring if using the insurance increases or doubles your out-of-pocket cost to get that same test?
Are you the only people? You use the word network, so apparently there are more direct primary care physicians there, and you're all united. Is it under one company, or is it just a group of people who put together an alliance?
These are all individual independent physicians
Individuals.
across the country. Started off with us.
How many
about
do you
12
have
years
in
ago.
Florida now that go under that banner?
We're probably about 150 in Florida and 2,000 nationwide in all 50
Wow.
states.
Wow. Any in Mississippi that you know about?
Absolutely.
We'll talk more about it. It does seem that the insurance companies have us kind of held hostage in one particular format, and it is great to see people thinking out of the box like Dr. Lee Gross. We'll continue the conversation with him coming up next. Shall we get back live in the Trustmark Studios? Our guest is Dr. Lee Gross, a distinguished physician from Florida, president of the nonprofit Docs for Patient Care Foundation, which is a national health policy think tank of practicing physicians committed to the establishment of an American health care economy which preserves the sanctity of the physician-patient relationship. I remember as a youngster having house calls. Will we ever get back to that? I doubt it. But Dr.
I make
Rose,
house calls.
do you really?
I do. Absolutely.
That is absolutely amazing. I mean, that was just, there are generations now that have no, if you show up at a house now, they probably call 911 in most places. But how is that beneficial?
How so?
It is certainly to the patient, but how is it to the practice? Can you afford to do that and still, I hate to say this, but in that whole concept here where you might be getting pushback is the fact that can you pay off your student loans with this? Can you make money as a physician? And I know you're there to heal the patient and everything else, but there is this financial part of that also.
Yeah, you may not make as much doing this as you do in the traditional practice, but also there's a lot less physician burnout. So job satisfaction tends to be much higher. We extend careers, so doctors that are ready to retire because of the burdensome system that we're placing on them doesn't really value their services and their professionalism. So it makes them want to leave the profession. Whereas this practice model is very professionally rewarding, and you're no longer just a cog on the wheel of the insurance company or the big conglomerates. You're actually doing the patient care. So, for us, as far as like the house calls are concerned, if a patient's too ill to come into the practice, if an elderly patient that may be on hospice, then we just go directly to their homes and take care of them. Again, during the pandemic, when you had a patient that might have had lots of chronic conditions, lung issues, that didn't want to come into the office and be exposed to people with respiratory infections, then we came to them.
Yeah. You ever go on a very rural call and they can't afford to pay you, but you come back with a goat?
Well, we get lots of eggs and chickens and so forth.
Well, that's true.
So that's a great point. So we do actually have another location. We have two offices for our personal practice, and one is in DeSoto County, Florida, which is the second poorest income county in the state of Florida. And we're growing this practice model out there. So again, if you can afford a cell phone, you can afford access to health care. But we have a 49-bed rural hospital, and as you probably know, most rural hospitals are floundering across the country, and they're closing almost every single day. And so this rural hospital in DeSoto County told their employees, if you sign up for this direct primary care practice, we will pay for it for them. And then they designed their employee health plan around our practice model. And they said, if this doctor orders anything through our health plan, they're self-insured, by the way, as an employer, the hospital is. Then if they order anything, it's covered automatically 100%, no copays, no deductibles. So if you listen to this doctor and get tests from them, it's free to you. Free MRIs, free surgeries, free hospital admissions. It's all included. The medications that they will cover, whatever Dr. Gross says is the prescription you need, that's covered. We're not going to hire somebody else to oversee the highest trained person in the chain. So it doesn't make sense to question everything they do. It's more expensive to put layers of bureaucracy. So it frees me up to practice. We're 4 years into that relationship, and we've cut their employee health plan costs by 55%.
Wow.
Not by raising barriers to care, not by increasing deductibles and blocking it and putting departments of people to authorize services and deny services and create formularies and kickbacks. It eliminates all those things and properly aligns the incentives, lowering barriers and access to care, and we've reduced the cost of care for the employer and for the patient.
The business model of what a physician is and how he or she operates in their lifespan as a physician has changed over the last 20 or 30 years or longer to where many of them work for a hospital or in a hospital. Can you do that and still be comfortable and without getting pushback from the hospital or medical association, et cetera?
Yeah, so we fill a certain void within the community that oftentimes are missed by the hospital services. And I'm not here to sort of beat up on the hospitals. That they certainly probably have earned some beating up, but that's probably not my role here today. But we do a lot of services that they don't necessarily want to provide or are able to provide. Again, we do a lot of indigent care. Which, when these patients are bouncing in and out of the emergency room with diabetes and infections and so forth, or horribly controlled blood pressure and can't afford to see a doctor to follow up, then we fill that void for them and take care of these patients that don't have actually access to the routine care. But we do so, again, the way we're able to provide these affordable prices is we have competition within our marketplace in Florida. So we do not have certificate of need laws in Florida that block competitors from competing against these large institutions.
Big story going on here. It absolutely is. So how long have you not had CONs in Florida?
We recently repealed CON on hospitals about 3 years ago. We have not had CON for imaging services and ambulatory surgery centers for quite some time before that. Yeah. But the reason I can get a $250 MRI is I have 9 different imaging centers to choose from. And so I get one imaging center that'll give me a price on an MRI, and they'll say the MRI is $350. And I say, okay, well, I will show that to my patients, and they can choose the $225 MRI, or they can choose the $350. I'm telling you, they're going to go to the $250. But and they compete on price and quality and service.
Those two things there would totally revolutionize. And I know Trump tried to get this thing done, and just the forces against are just too powerful. But those two things that you just mentioned, Dr. Gross, transparency and competition in the marketplace, would transform our health care. But we have so many people fighting against that.
Well, when I first presented this practice model in Washington, D.C. to a group of physicians, and at the time I was charging $83 a month, and the first question out of the audience was a doctor saying, well, what happens if somebody sets up practice right next to you and charges $40 a month? And I said, but if the first question out of the audience is going to be what happens when we reduce the cost of healthcare, we're on to something, because nobody's ever asked that question before in the United States. But what's going to happen is that doctor and I are going to have to compete on price and quality. I'm going to have to justify to the patient why I'm twice as expensive or lower my prices. And we'll figure out what the actual cost of the care is. And in fact, that did just recently happen. I had a direct primary care practice that set up across town from us. They're charging $120 a month. I had a small business that wanted to sign up as employees. He went to that doctor and said, hey, Dr. Gross is charging $80 a month. You're charging $120. Will you match it? And they said, no, that's our price. And so they took the entire employee panel over to our practice. We're competing. It doesn't happen anywhere else in healthcare.
Yeah. How do you mesh telemedicine into this? Is it an additional charge or just part of the monthly fee?
Just another tool in the tool belt that we use at no additional charge.
As far as telemedicine is concerned, so you'll pick up the phone and call the doctor, and if you need a prescription, et cetera, et cetera.
Exactly. And so you just snap a picture of a rash and text it to me.
I got to ask you this, because you and I don't know if you're going to be talking about this during the I think it's 11:30 this River Hills Country Club, 11:30 till 1:30 today. You said that the rural hospitals in your state in Florida are having the same problems here, and you think mostly across the entire country this is the case. Would you speak about that?
Yeah, right now the problems are immense because the cost of labor is massive. The cost to hire a nurse at this hospital, they're paying $190 an hour for nursing care. That's how much it costs to retain a nurse. So when they had the flow of nurses around COVID, all the Florida nurses left to go to New York City to be travel nurses, and so we had a massive shortage of nurses. So you had to bring the New York nurses down to Florida to pay them travel wages down here. So we basically just swapped medical staffs and massively escalated our labor costs. So there's that, and then the Medicaid that does exist in the state of Florida pays so low it doesn't cover the cost of the actual care. So if you have a heavy Medicaid burden on these rural hospitals, expanding Medicaid and just putting more people on the Titanic, just stopping and picking up more passengers. So
what are they doing? What are they doing to stop that hemorrhaging in some of these hospitals? Because we have a report this morning. There was a new report out there that we have of about 70 rural hospitals that are threatened in our state. They apparently have done a little bit better in the last audit or whatever, and now we got about 19 that are about ready to close or shutter.
Right.
But culture has changed. The populations in small towns are just dwindling, and I would guess that a rural area of Florida is not a lot unlike in Mississippi.
It's not. So if you look at the line item expenses for a hospital, human labor is probably the highest cost. Beyond that is the employee health plan as a line item in the budgets for these hospitals. So again, what we did in DeSoto County is we cut their employee health plan cost by 55% and it's maintained it for 4 years. What we also did was we created a transparent cash-based surgery program. So we charge a fair price for colonoscopies, knee replacements, hip replacements, and we now have patients coming to this rural hospital from across the state of Florida to get cash-based surgeries.
We got a break coming up. I want to give you the final segment here. I just got a quick note here. What's a colonoscopy cost?
Colonoscopy is $1,400, includes the surgeon, the facility fee, and all the pathology services.
From a hospital with insurance, how much would it normally be?
Normally it'd be $3,000 to $5,000, and if you had a history of a polyp, that would go towards your deductible.
Wow. Final thoughts from Dr. Lee Gross coming up next. We'll be live from the Trustmark studios across the state, across the nation, around the world, wherever Mississippians are gathered. Well worth mentioning Mike in Gulfport as people across the state are chiming in on this. We are talking about direct to primary care. Mike in Gulfport says doctors having to see 30 or more patients every day to stay afloat and make a good wage are tired and looking for something like this. My doctor went to a similar organization. Now his patients and him are much better off. He told me all he could do is practice medicine as he's trained for prior to the change. And he was rushing to so much more. He felt guilty about not having find out all about the patients that he needed to. The guy's program sounds, this program sounds even better. Bradford and Blue Springs says, do they offer a family package? And the answer is what, Doc?
Yeah, so we charge $80 a month for the adult, $30 for the first child, and $15 for each additional child. And that after that, we charge nothing. And for us, a child is up to the 26th birthday.
So if you got to have a follow-up and the kids they got runny noses as much as the TV's on. I mean, every day it's a runny. If you got 2 or 3 kids, they're going to have runny noses and things like that. Most of those, when you develop a relationship, you probably can kind of figure it out and just call something in, I would imagine.
We can do a lot over the telephone when you have that relationship with somebody, and so we can accomplish something with 5 minutes over the telephone that would take you a half a day away from work to come into my office.
Somebody asked this, and it's a good question. If does anybody in the network do surgery?
So we have cash-based surgery prices to do.
But are you allowed? Do you have them in your facility, or do you just go to a hospital?
So I do minor surgical procedures in my facility. So I'll do skin cancer biopsies. I will remove small skin cancers depending on where they're located, and so we'll remove drain abscesses and sew up lacerations and splint broken bones and so forth. That's all done within our facility. If it requires more expanded surgical procedures, then that goes
something like that. You refer them to
or like a gallbladder or so forth. That in most cases can be done in an outpatient ambulatory surgery center. Again, if you're allowed to have them, if you're allowed to build them, that is a much more affordable option to get surgical service. So we have cash prices for all that.
Do you think this is catching on across the country?
No doubt. Absolutely.
Yeah. You said that we do have these in Mississippi. You told me a number, too, and I forgot the number, but you said there are quite a few.
I believe there are over a dozen here in Mississippi, and I didn't look at the number just
under
recently.
The direct primary care label?
Correct. So if you were to go to the website dpcfrontier.com, that's dpcfrontier.com. They have a map that you can look at that you can pull up the different independent practices. Again, I have no financial relationships into these practices. I don't own them. They're all independently owned and operated.
dpcfrontier.com is
and there's a mapper there.
That'll show you. Your advice to some of these doctors who may be getting to the point where they're strung out.
Yeah, they're getting strung out in residency. That's the thing, is we're burning these doctors out in training. That's how broken the system is. They're spending their entire time working to generate revenue. Doctors are hardworking people by nature. You don't get to become a doctor because you're lazy. So these are hardworking people. They want their work to have value. They want it to have meaning. And so doing something to generate RVUs for a corporate employer is not valuable to a physician. It's how many lives did you save? How many patients were you able to counsel? And so but we're burning them out in residency. We have a better way for them. There's a better way where they're no longer tied to the large corporations and large hospitals. They can actually work for their patients again without all these middlemen in the middle of this relationship telling them how to practice healthcare. And it's a very freeing experience, saving a lot of careers.
Over the many years, we've had a lot of doctors who are part of this family every morning and kind of the consultants of the program. But over the last couple of years, having some medical conditions, I've had a chance to talk to some of these doctors, even more so than normal. And you are right. The red tape and the stress is killing a lot of them. They would like to practice long beyond what the normal retirement age is, but for some of them, it's getting to them. It's not getting any better.
No. If we talk about, we have a physician shortage. Mm-hmm. Well, if the estimates are about 50% of a doctor's workload is non-clinical care bureaucratic paperwork. If we were to just cut that paperwork processing down in half and remove those, we effectively overnight double the workforce of our physicians.
Would you, because and I want to clear this up with so many of the different House and Senate members listening to this program each morning, you would not attach the deletion or ending of con to any of the hospital problems as far as competition in Florida?
No, my practice is located in the largest city of Florida without a hospital because when we had the con. So we were applying for a con for 20 years and were rejected.
Wow.
So now the con is overturned, and the hospital that appealed against our con is now building 2 hospitals within our community.
Look, if you haven't registered, I'm not sure if there's still a chance to register for this or not, but if you want more information, the information on his talk today at 11:30 at River Hills Country Club in Jackson. And if you want more information, go to the Mississippi Center for Public Policy. It's there. Sir, thank you so very much for spending some time with us. If you want more information, go to dpcfrontier.com. Dr. Gross, welcome to Mississippi.
Thank you.